Okay, uh, let's go ahead to the last sessions, and this session is about the fusion lecture. You know, this morning we have introduced cervical endoscopy techniques and also the transformina, and this is for the lumbar posterior fusion case, and then we use the large channel. I'm Dr. Shu, and this is my lecture is the uniportal large channel endoscopy lumbar fusion and body fusions. And I would like also use 1 minute to introduce my hospital. We have 7 branch hospitals and total about 10,000 surgeries and 5,000 for the spine surgery 1 years. And in my department, I'm in the general hospital department is 2,000 for the spine surgery 1 years. And this is the new NASA branch is nearby Hong Kong, in the centers of the Zhujiang area. Zhujiang area in the central Zhujiang areas. So with the developments of the lumbar endoscopy fusions, is maybe the dramatic development these years, maybe from the 2080, everything changed, especially in my departments. No, most of the fusion case, 1 segment or 2 segment in my department is performed by the endoscopy, especially in my group. I have 3 group for the endoscopy surgery and 2 group for the open surgery or traditional case. They are also doing the transforaminal or interlaminar, but they will not do the fusion case because they are still for the traditional. But I still have 3 group for the fusion technique. The advantage of the lumbar fusion, maybe they are also telling that the faster recovery and the minimal invasive, and maybe the the big advantage is the following outcomes of the patient. Maybe the following outcomes of the patient also will say I is very good for recoveries and can go better to work fastly. And disadvantage, we are also because this technique is going very is spreading very faster over the world. But because most of the pioneers of this technique, they telling the disadvantage. One is the learning curves and the surgery time. If you have so many time for 1 days, and this is a waste of time in the past. But now in my team, the times of the surgery is the same with the open surgery, or even quickly than the open surgery. Maybe you can see the today or tomorrow in my operating room. Because we have faced many, because with the efforts of the export or around the China or around the world, especially the mid surgery, mid surgeon, they are overcome the learning curve, or they are changed the techniques, or they are maybe develop the tools, especially for the endo surgery. Now the learning curve, most of the daughter afraid to perform this technique is the learning curve is very maybe it's very higher, and especially in the past 10 years, most of the case maybe is 4 hour surgery times, and so many detail to perform in the surgeries, and then how to avoid the destroys of the nerve roots, and how to avoid the dural test, and so many times, so many things. Especially the fusion case in the past, the first team in China to perform this technique, they are saying that the lower rates of the fusion rates, the lower is lower than the traditional missed LIF. So there's many academic problems for this technique to go ahead or to deliver. So my team have overcomes and phone call on this technique for about from 2017. We do the first case posterior interlaminar. We call it interlaminar. It's just like the traditional surgery. We chance to the endoscopic. So we overcome this maybe four problems, and then we go ahead with how we do it. And maybe I seen it for the indication. So why we change to the interlaminar fusion technique? Because the transformational fusion technique is just used for the easier case, but the severe case, especially the spondylolisthesia or very very difficult case, maybe the posterior is the good technique for this. So we change to the posterior fusion. Maybe we call it endopelif. Maybe we call it endopelif. So this technique is for instability case or very serious or recurrent case, recurrent surgery case, and or even more less than grade 2. So we change to the fusion. Maybe the first step is the incision. Now the in 2017 we cut it like this. It's as Oliver. Maybe not the vertebra, or it just because we like the wound is nearby the bony depression point, so we cut go more medial right, or the central right, like this. So we change the fusion technique from the transforaminal to the interlaminar like this. And this is also we call it the endopelif technique. It's just like the interlaminar technique. We can do a bony wards. So we classify. Maybe we summarize the technique to 4 parts of the surgical procedure. One is the bony wards. The bony ward, we use the rimmer so to harvest the bone, and then can do a very good implants of this space. You can also use the diamond, or use the punch, or use the chisel to perform the bony decompressions. And the second step is the depressions of the yellow ligament. You see, the yellow ligament is not braiding. We call it the very clear views, because there are no braiding in the yellow ligament, in the surface of the yellow ligament. And the third step is the deep space. We call the bead endoscopy, especially the uniportal, is go just like go deeper and deeper. You will not turn back to the surface. We just go deeper and deeper, and then go into the space, and then put a case, and then finish the case. So we can do it. Even for the easier case and half hour, we can put the case in, and then the pedicle screw. So for the easier case, for me, 1 hour and 10 minutes or 20 minutes is enough for the total surgeries. And the difficult case, maybe it's 2 hours from the incision to the pedicle implantation. So how to understand what we are doing, and the approach. So first of all, you had to understand 3 lines. One line is the inner part of the SAP. This is the inner part of SAP, and the upper part of the laminotomy. So you had to find this first when you are using the rimmer to do the bony appendage. You had to know, because the endoscopy surgery is easier to lose your weight. So you had to make sure where you are. Even in the first step, we use the navigation. Use the navigation to make sure where where we are doing and how large we had to do to make sure. And now the first slide is the bony landmark. It's very clear when you cut the IAP, and then the first slide you can explore the first slide like this. And you are doing the decompression like this. And when you are doing the decompression in the middle of these lines, you complete the decompressions of the transverging loop. So everything is according to life, because it's the landmark. And the second landmark and the three landmark is like this. I identify systems. One is like this, second and the three. Three is for the UABD. You know, when you are doing the bilateral decompression from the one side, you had to make sure that the decompression is enough. One is you can see the the contralateral loose. Another is make sure the bony structure is cut enough to have a good decompression. So this three line is for me is for the endosurgery technically very base analogies and very important analogy for your when you're doing the surgery in the first steps. So will you go ahead? And we have also a 5 area for the decompression strategies. You know, when you are doing a fusion case or decompression, the the first thing is to have a strategies where I will do and where to go first and the second. Now I'm doing decompression like this A, B, C, and D, and even if the very serious case, and I will do the E decompression like this. So we can see some case, and I had to enhance that. The C area is very important if you want to do a contralateral decompression here. You had to maybe we call it the overtop technique before, but now we sometimes we call it a transfer。以前讲就是 over top， 现在我们讲跨越transfer is more higher to go to another size because and more higher you will not compress the canals or the dura and it's more safe when you're doing the second and the contralateral size. So more higher more higher, and then we are decompression the central C using the diamond or using a reamer or using even the chisel to upper, and then you just like you open a dock and then to the second size like this. For the EZK, it's just only for the area decompression for the contralateral decompression, and if the severe case, and then you will do a big, maybe destroy some parts of the contralateral IAP. And this is the UABD technique for the posterior. You see. Now we start at with the IAP here, and we make sure the first line here, and then we stop use the reamer half reamer to go upper like this. If you are not familiar with the reamer technique, you can also use the diamond. Especially the large channel diamond is bigger than the normal one, and the efficiencies of the diamond is also okay. So you can do like this. This is the area, and you find the first lines and the A area, and then you can explore the second life. Second life, you can know the central of the second life is the transversion in loop. So everything is according the landmark, according the land structure. So you have no need to have a navigation in the first step. You according to the bony structure like this, and then the C area You see the area. Oh, the video is not very good. I say if you go into another size of contralateral, you can cut some parts of the central area. And if you want to do a very good decompressions of the contralateral, you have go higher and maybe it's upper in the central, and then you can do a good decompression of the contralateral side, so like this. This is the maybe the transversion loop, and then you cut the first slice of central, and then you can expose the transversion loop. Now here is the central of the yellow ligament, and then you use it for step to grasp it, and then the contralateral size. You can see the third slide here. If you find the third slide here, and then you cut some of the bony structures of the center of the first of the third slide, and then the contralateral transversion loop is decompression enough. Most of my case, I don't need to explore every transversion loop because I only need to make sure this is a third slide, and then cut the center of the bony structure, and everything is enough. Sometimes I will use the Prof to make sure the contralateral, but you don't need every case because you are doing the decompression according to the bony structure. Okay, go ahead. Okay, finish when we finish the decompression. Decompression that is very good and enough. So when you using the UFBD technique with the lumbar fusion, so everything changes. You know, for the first steps we do the endoscopic fusion for the easy case, but now we're doing the and lumbar fusion most of the case, even the severe case. I will show you in the later presentation. Okay, this is so you can do a whole decompressions of the spinal cord and a good very implants of the bone graft. So why we use the remote technique? One is very efficient, and another reason is we can halve it all of the bony, just like the chisel, to have it all of the, and even uh, we can put inside a hole, just like a step to support the space. I have to do it there. One a bigger one, about 10 millimeter, and then you can put inside the space. It's just like the case put inside. Suppose the space, and then we prevents of the maybe the cracks of the space, and we also modify the bony graft preparations. We have a very good preparations of the this space. Now, in the first step, it's like this, and now we do it most of the case like this. Like this is a very good preparations from the this space, very good for fusion. Now this test because everything is under the endoscopy. So when we compare with the traditional, maybe we just use it to you cannot make sure 100% your good predictions of the this space prediction, but everything under endoscopy, everything can make sure, you see, and most of case you can see very deeper. If in the traditional open surgery, you are afraid of the anterior structures, but under the endoscopy, is very safe, I think. So after the protections of bone implantations of here like this, very good implantations of the bone and very good supports of this space. So maybe this is the technical detail, the advances of the endoscopy fusion. Sometimes we also do a microfracture like the maybe like the accuracy technique to maybe to enhance or raise the rates of the fusion, just like this. Two parts of the bony wall can hold together, and then I put the bony, they will fusion more faster than the traditional. Uh, some case with that. And then we have a good support like this, good support implantation like this. You see, this one, case two, case three. Every case is have a bit. It's just like the bone graft is just like the case. A big case, just like the olive case, very bigger, and the support is, and it's advantage than the olive case because it's the bone. Bone is the same with the vertebral, so you cannot suppose and will not destroy the end break. I think end plane. I think you see, this is the 6 months follow up. You see, the correction rate is less than the traditional. You see, and some case we find some case. This is case 9, 10, 11, 3 months fusion. 3 months you can see the fusions of the bridge of the bone. You see, the bridge of the bone because this is a bigger one bone and suppose in the anterior. So and we also do a microfracture here, and then give you maybe fusion is more faster than the traditional like this. It's very maybe a small modifies of the detail and everything like this. The procedure like this procedure, bony plant and cage and the controlators. And then we also use this half tube protector. It's just like a protector and a control, but it's a half tube, so you can put from 10 to 40 case. Even use the normal case, even use the traditional case. You don't need to expand case, just the normal case. Most of my case is the normal case to put it. It's just protecting the ejecting loose and the transversion node, and then you put like this. It will not go out because the half tube system is just like to hold the case go inside. It will not go outside and anyway. So and with some other technique for the lumbar maybe the narrow of the space, maybe the spondylolisthesis case. We use, you see, we can use the distraction, use the working tube to do a distraction. You know, when the traditional case use the pedicle to do the maybe the enlarge the display or use the spatial. But we use the endoscopy. You see, we always use the working tube to do a very good enlarge the spatial, and then you can do a very good preparations of this space. Before we doing like the narrow case like this, only just okay, and now everything is clear and everything is more maybe satisfied for our daughters. You see, this is a very narrow case, and then we relieve, and then we enlarge. And before we use the pedicle to maybe to enlarge the display. Now we use the working tube. You can see some case. For this case, you see, we use the pedicle to reduction before, but now we use the endoscopic working tube because when you enlarge the display, most of the reduction is complete. Just like the olive, when you put olive a big cage and then the reduction is maybe a completion. And this is a chance. You can see some case very serious, very serious stenosis. We use the posterior endoscopic fusion and have a good ULBD decompression like this, A B C D E. The whole canal decompression, and you see the posterior. This is a jaundice. This is a jaundice. Yeah, you can see the jaundice. Posterior the second day. It's very good, just like the normal. And this is a throw up posterior. You can see the corrections of the display is very few, and the fusion is very good. like the case like this, and there's and stenosis case you can see like this. We can put a bigger case. Now I show you the detail. Now stenosis one, you see, with pros and relief, and then put a working tube inside. You see now he's in large space, and then you can put your endoscopy inside the this space, and you can clear the this space more easier and more efficiencies, and maybe it's more beautiful than before. Uh, so the posterior of the bone graft, you see. Yes, this case for bilateral. Bilateral, you can relieve everything. You can relieve everything. I will show some severe case later. So this technique is very good now in clinical work in the police. You see, this is bone to bone. When I decompress one side to another side and put this is my spatial tool, a painter for just like a spatial. You see, when I pull my spatial and then this tool we are push the working tube inside and see the reductions of the spondylosis happen. Maybe the maybe it's more easier for the pedicle screw. You know, before the pedicle screw have a fit hard and then to the reduction. Now everything changed. We do the reduction using the enlarge this space, and you see when put a big cage inside, the reduction is very good. You know, so the pedicle is we are no uh, so much important for the spondylosis case now in my team. Yes. So the severe case like this, uh, also a severe case and then relief and then reduction. You can see relief bilateral, just like the traditional bilateral. It one half hour more for bilateral size, but it's more easier for you doing a UABD. UABD you had to face the dural tear and many when you're doing a C area enough depression. You know, C area is not enough decompression. It's very hard to go to another side. So change your idea. I do it bilateral. There. No. We have two endoscopy. We have to and the maybe the video so you can go to another side very easier. I have by maybe the TV, one TV and another TV, so you can do any another side. Especially I'm doing the endo surgery of the ACDF. I can do it one side or another side for the endoscopy. It's not like the traditional. You can see the posterior X-ray. The posterior X-ray very good because the enlarge of the display, so the reduction is very good and enough. And you see the bone graft sufficiency and severe case like this. You see like this is a bone to bone, and you see we use bilateral decompression. And the second we use the spatial, and we use the working tube to enlarge. You see, no, I just know use the pedicle. Now the reduction is almost okay. You see the pedicle is pedicle school, you know, so it's more maybe more good for the traditional way. It's different from the traditional way. So this is a posterior, a very serious case, a very serious case, and then the posterior like this. It's almost like the normal, almost at least 9% reduction, at least 9% reduction, and it's by so I think maybe the BLBD bilateral decompression and the ULBD one lateral decompression is maybe can cooperate together. Some severe case maybe I think it's the bilateral decompression more good than the ULBD, and the easier case for for ULBD is so the outcomes of our surgery of my team suppression outcome of my team is so in my case the the complications in my team, the complication is the same with the TLIF. Some is the weakness of the leg or weakness of the neurosurgery, and some is the dural tap. And for the fusion case, the dural tap, a small dural tap is don't matter because the water because the the working area is more bigger, so the water come out easier. But for the cervical, it's more maybe I think I phrase more. And we have also tried for 2 cases of the scoliosis. You see, because we don't use to we don't use to crash of the curve. We just put a bigger we just put a bigger cage and very good support of the bone enough, just like the olive, just like olive. So, but you see, when you're doing olive, you had to go in lateral and then transfer posterior. But not, I'm doing the endoscopic fusion. All is posterior and without jaundice. You see, without jaundice, it's just my thing. I think is for the easier case, it's okay. But the severe case is traditional. Maybe it's more good than this. It's just a new choice for 2 cases of this. So the conclusion, the summarize of this endoscopy technique. Now the technique in my team is very efficiencies and sufficiency for decompressions, or even have many advantages for the fusion compared with the traditional. And I think there is many detail I mentioned that there are many disadvantages we have to account for. So maybe all friends or daughter come here, then we can discuss some more about the disadvantage and how to avoid, and we also can get this technique in your clinical works and have a good outcome for your patient. Thank you. If any question, we this Friday we are work together. So anytime any question we can discuss them together. Even the technical quiz or the training course. So we are go ahead to the model training, and